Thanks, Patty. Yeah, we're going to talk about stenting for chronic post-thrombotic patients and, where those stents fail and if we can prevent that or salvage it. Disclosures. So certainly we can get good results in these patients. I mean, this is one of mine. Obviously, she's much better after treating her, and her, stent looks pretty good. All major trials have shown that we are improving their quality of life, and we are, improving their venous outcomes. But where are the problems still? Where are our hitch points? Well, we still have 3-year patency, 70 to 80%, and I think Black put out a paper that's even some places closer to 50%, depending on those inflow. Why do these stents fail? I think it's not always understood, and can we prevent it or salvage it? So those are what we're going to cover. What I see most commonly is that there's this misconception that veins are actually more forgiving than arteries. Well, maybe in some ways, but the same thing that prevents you from, not bleeding out on the table because it's a low-pressure system is also the same thing that makes your stents fail because it's a low-pressure system. So now they don't tolerate any imperfection because any imperfection in that system leads to clotting. And in truth, a lot of the issues I see are still judgment and technical errors. Certainly they're not on purpose, but there has been a global lack of education in the space. Technologies come out faster than our catch-up on education. And this results in these stent failures. And we should be probably looking like that in many of the cases when we're staring at that. And these stent occlusions can be very difficult to fix. So we got some tips to avoid this. Patient selection is paramount in all cases, even in your post-thrombotics. You won't die from this problem. I'm not trying to undersell it because it's a big deal for these patients and it can certainly improve their life if you treat them. But if they're not going to be compliant, I don't offer this. So if there are patients who won't take their blood thinner, who aren't going to show up to follow-up, then they're not stent patients. They need to be symptomatic and they need to have adequate inflow and outflow, just like all of the arterial patients. I get a pretty extensive workup before I get a CT scan. I know pretty much everything there is to know before I go there, including where my profunda is. I get iliac duplex, I get reflex testing. We go through kind of everything pretty extensively before. When we get to the procedure, it looks like your normal steps. There's a couple details at each one that we'll go through that'll help keep you out of trouble. So for access, for post-thrombotic patients, you do not want to use your common femoral vein ever. I said no isolated common femoral or GSV in this case because while I prefer strongly to use the upper or mid-thigh femoral vein so that you can visualize the entire common femoral right to the lesser trochanter, I will on occasion when that vein is difficult to get into use the GSV, or I've even used the ASV. I use it to cross, and then I'll come down from the neck. That way I can see the distal common femoral vein and stent into the, or stent to the level of the profunda. I can even balloon the profunda and femoral from the neck. Occlusion does not preclude use in the femoral, so I always try that first. And again, I kind of know where my profunda is before I get there in relation to that lesser trochanter via my CT scan, so I know where my access needs to be. So with looking at access, we'll look at our fail points with each step. This case, they did a nice recanalization of an occlusion. They stented it. This is an old case that I had when I first got to where I am now. The post-IVUS looked good up until you got to the sheath, and you can see there's some disease. Well, their access was common femoral, and it was right at the level of the GSV, which is at the bottom of the femoral head. And so what this guy had was a really early predictable occlusion because he had distal common femoral disease near occlusive and now occluded below that stent. So the stent was open for a very short period of time. I got him referred a few years later, and that's his ultrasound. He had a perfect landing zone, which would have been, one of those 95% patent people at 5 years, and instead, I couldn't get through that stent. So we really need to get these right the first time because you have a occluded iliac for 10 years, 20 years, I can get through it. You have an occluded stent, 6 months, 1 year, we may not be able to fix it at this point. I do venography, but I do it only at the start, only at the end to kind of get an idea of what I'm up against. It gives you some clues on pathology, may give you a sign where to take your wire. But mostly I use IVUS. After my initial venogram, crossing, this is not typically the hardest part of the case. I would say it is until you realize the differences with arteries and veins. So you want to stay interluminal. You want to lead with the tip of your wire. Occasionally I'll let it loop, but usually I try not to. You're trying to find little channels in these trabeculated occlusions to get through. The other thing that's very different from arteries, pull your wire back if you're not making progress as opposed to sticking with that one spot because you're trying to find a new channel. Wire perforation is not a big worry. This is your biggest step here. Get a lateral. Make sure that you're going anterior to the vertebral column. If not, where it goes wrong points, you can be in collaterals that are often into the spinal plexus. This is one example of being in a collateral. And then you can also go into the spine, into the vertebral column. This patient had bilateral foot drop, was in rehab for months. She was in her 30s. I've now seen this in probably 3 or 4 different cases with 3 or 4 different docs, so it can definitely happen. After you cross everything, you're going to want to confirm it with IVUS. I always determine my confluence location by IVUS and actually mark it on the screen. It can be about a full vertebral body, different from venography, depending on the angle, and it doesn't necessarily look like it would be off if your gantry angle is not fully open. If you get, this is what it should look like, without jailing the other side, the bilateral stents there, which I don't do very often. And then if it goes too high, you get contralateral jailing. They're kind of messy fixes when this happens. So again, it's good to do it right the first time. A lot of our fixes are a bit of jimmy rigging, which is not something you want to do in these patients. Also, if it goes too high, if you stent like we used to, where it's like kind of leaning on the cable wall, you can get these erosions. I would stay away from doing that. If it's too low, especially if you use a short stent, which we tried to teach people not to use anymore, they can watermelon seed backwards if the May-Thurner is pretty tight, and you can have erosions there, and you can also have just recurrent symptoms. Again, the fixes aren't great. The fix for this one was pretty easy, just extending it, but the erosion, I actually had to remove the stent. Distally, you want to pick the best landing zone above the profunda. Again, that determines really, that's the whole case, is making sure your inflow is good in a lot of ways. It's the most important part anyways. That's what I fuss over. Most of the time you cross the ligament, you don't want to jail your profunda, so find it, protect it, be as close to it as you can without crossing it in these patients. Other things that we see, the most common cause of stent occlusions and failures is just a fear of getting too low, so not wanting to cross that ligament, leaving disease underneath. Remember, any disease can be a trigger for recurrent thrombosis, especially if the patient, something happens. They come off their blood thinner for a day, or they get sick, or they have a surgery. The patient on the right was stented with an occluded femoral vein, and that's the profunda. There's no flow. If you don't have flow in a vein, you don't put a stent in. So if failures occur, you want to treat them as early as you can, or try to salvage them before they occlude. Chronically, they're difficult. Make sure they have inflow, because if they don't have inflow, there's no point in spending so long trying to open them, and then you're not going to be able to keep them open. Keep them anticoagulated. I like the spectromagnetics laser, which is now Philips, for crossing them, but we don't have good debulking tools if it looks like that one I showed earlier that was dealt with open. Deal with why it occluded, and make sure that patient knows they have a high-risk stent. This is going to be something you're going to have to fuss with for a long time. They really can't miss blood thinners. So other things that can occur, if you land in a curve, you can get jailing of the distal vein. This is the case with the erosion that went through after watermelon seam backwards, and my partner and I removed it. Set separations if you land them on a curve without good overlap. So there are other problems too. When you're doing these patients, make sure you're dilating them to the size of the intended stent. You're going to put in, the stents should be 14 to 16 in most cases for your post-thrombotics. It's very rare to need an 18. Plan your stent lengths, about 2 centimeters of overlap, not under the ligaments. Post-dilating, make sure stent's stronger, and make sure that you're taking care of these patients post-op, right? So I do Lovenox early, then DOAX. I'm looking at them pretty frequently. So overall, best results are with attention to detail. Really, the key points are landing zones and inflow. I see a lot of people take their post-thrombotics off anticoagulation. I don't know why, because that's a big failure point. A lot of these patients remain high risk because they have scar in their inflow. So if you have really good ultrasound that says there's no scar and no risk factors, okay, but I would lean towards leaving them on indefinitely. And then most complications are preventable or foreseeable. You should at least know they're at risk, and the patients should know that too. Salvage options are really bad. All right, thanks.
Thank you, Erin. I wanted to ask you a question. Have you ever seen this syndrome, which I call the bikini line syndrome? Because patients come back and they complain about it hurting right here where their bikini line or their panty line is. It's usually women, and I think it's the inguinal ligament of some sort.
I've only had that a couple times when the stents were a little bit on the bigger side with nitinol. I had 2 patients that really needed a 16 all the way down, and I used a 16, and they had groin pain, but only for about 2 weeks. It went away. I have had it in a couple wall stent patients, and I think that maybe the wires are eating through the vein. We've actually removed a couple for that indication, and it did help, but it literally was a couple, so I don't know. But I think those sharp edges, when you go in there, you'll see them just poking out. I wonder if they're hitting a nerve or something.
Thank you. Anyone else?
Yeah, we usually, whenever you put stents, can you hear me with this? Whenever you put stents, there is some back pain, groin pain for about 3 to 5 days, which responds very well to non-steroidals. But I've had a few patients who have had lingering symptoms for several months. It gets better, but then with positional changes, getting to the car, coming out, it can reproduce itself. It's never a deadly situation, but it's an inconvenience.
Thanks, Masha.